Good evening, everyone. Here Imran Abbas. Again, we are live, and I am from Dubai, and Professor Alexander from Russia. It is great honor to take live Professor Alexander from Russia. He is a well-known bariatric surgeon. He is a ex-president of Young IFSO, as well as he is a president of Obesity Society of Russia. So I will not take the time. Professor, highly welcome. It is a great honor. As you know, we have started this series of safe sleep gastrectomy since July 2021, and this series will continue till December 2021. What is our target in this COVID era? To convey message for our youngsters by someone who are expert of sleep gastrectomy. As you know better than me, so sleeve gastrectomy still is the most common bariatric surgery at the globe. So yes, we are facing some complication of sleeve gastrectomy. How can we decrease these complications? So yes, we can decrease with the expertise, with the so better technique. So due to this, we arrange this interview series. And in this interview series, my viewers, you have this opportunity to ask any question from Professor Alexander. Professor, highly welcome. Over to you.
Hello, Imran. Nice to see you. Nice to hear you. Hello, everybody. It's a great pleasure for me to be a part of this educational program. And I hope I can help for young surgeons to find some tips and tricks about sleeve gastrectomy, and we can discuss all these things. I'm completely agree with you about sleeve gastrectomy. It's very popular, still popular, and we know that it's maybe more than 50% worldwide. It's really a big amount of procedures, and sure, it must be safe. It's very tricky questions how to do it, because if you look at first time, you understand that you think that it's very simple, but as you know, all simplicity, it always big way for mistakes and other things. Okay, let's start.
Professor, really, so much thanks for your time, and it is great honor for all of us. And definitely, you are also part of GLR, and as a GLR faculty, you are part of the team. You know better than me, we have series of questions, and we repeated questions. So because at the end in December, we will have some obsession. Sir, your brief introduction. I personally know you, but so most of our viewers, they also like to know about you. Your brief introduction.
Okay. My name is Alexander Neymark. I work in Russia, St. Petersburg. It's a very beautiful city on the northwest of the Russia, and I work in very big national research center, medical center, Almazov National Medical Research Center. It's a big unit of different specialties, and sure, the bariatric surgery too. Most time today I spent in bariatric surgery. At beginning I was as all, I think, bariatric surgeons, abdominal surgeon. I do oncology, endocrine surgery, and other type of surgery. And now I chief on the research laboratory of metabolic disorders, and I'm a chief of the department of the metabolic surgery in St. Petersburg, and I continue my work in this field now.
Excellent, sir. Excellent. And please share what your journey in bariatric surgery, when and you have started bariatric surgery, and about your journey of bariatric surgery.
It's interesting history because in my residency, I started general surgery, and one of the professor, it was Professor Sedletsky, Yuri. It was famous professor in Russia because he was one of the first who started bariatric surgery in USSR, and he proposed to me to do some scientific work in metabolic surgery. It was interesting for me. I look, and my journey starts from the procedure, names of this procedure, GIB, jejunal ileal bypass. It's a very old style procedure. It was open style. It was laparotomy. And I start to attend in these procedures. I start to contact with these patients, and year to years, it's more and more involved me in this process. And sure, I understand that it's very interesting field. And I continue my work. I specialize in different procedures by laparoscopy. And sure, we start a laparoscopic approach in bariatric field. And we start gastric banding, then we start sleeve, and my career start to be more and more active in bariatric.
Sir, excellent. Excellent. Yes, because this is another time to talk about jejunal ileal bypass. That is also an interesting field. And nowadays, especially in low BMI diabetic patients, so one of the most interesting and going to popular surgery when we do any variation in gastrointestinal tract, yes, due to rise of GLP-1 and that metabolic impact of bariatric, and one of them is also jejunal ileal bypass. Definitely we will talk about this in our next series in next year, but now because our target is sleeve gastrectomy, so we will highlight these questions. Sir, when you have when you have started and why you have started sleeve gastrectomy?
The first sleeve gastrectomy, it was performed, I think, 2008. But it was a very difficult procedure for me at this moment. First reason, it was that we don't have so many spread video contents. We can find something. It's only in 2005 I visit the first IFSO Congress in Maastricht, and it's the first time when I see the sleeve gastrectomy, and it's only start to be popular. And sure, it was very interesting because as I told, when you look at first time, you think that it's very, very easy. But the first procedures was not easy because you don't understand technique, you don't understand trackers placement, you don't understand how to use the staplers, and many, many different things. But anyway, it started in 2008. The other reasons the progress was not very fast. In Russia, bariatric surgery, it was very unpopular. It was nobody knows about it. It's only a few surgeons who do it, and sure, it was very difficult. Endocrinologists don't know, and sure, we're doing 20, 30 patients per year only. It was not too much, but it was the experience. And only, I think, in 2015, it started more and more and more 50, 60, 70, 100, 200, it started to be more and more patients. And sure, the learning curve was very long, and but anyway, it gives me possibility to understand how this procedure works, how the patients suffer after this procedure, because when you don't go many time in OR, you have a time to spend some dialogues, some visits with patients. It's very useful for the bariatric surgeons, I think. And now it's most common procedures in my practice.
Sir, excellent, sir. Yes, now more than 1 decade you are performing sleeve gastrectomy, and I know you are well-known bariatric surgeon in this area, and also you are also president of Young IFSO, at least for 2 times, as I know. Now at this stage in 2021, what percentage of your total bariatric surgery belongs to sleeve gastrectomy?
I think it's 65, it's sleeve gastrectomy, 35, it's other procedures. I think 25, it's different bypass, and maybe 10% is redo procedures.
Excellent, sir. Sir, as you know, you are surgeon and you are well-known surgeon now about 2 decades. You are surgeon. So definite, a surgeon always change his technique for better results. So have you evolved your technique, especially for a sleeve gastrectomy, for better results? If possible, please share the changes you have made to decrease late or early complication of sleeve gastrectomy. If you can show any video, show any presentation.
Yeah, sure. I have a presentation. We just start my presentations. Sure, my technique is changed. But I think the last maybe 5 years, it's the same technique. Okay. And maybe I stop because we minimize all the complications after sleeve gastrectomy. We on this moment, the last 5 years, we didn't see any leaks. And the only one complications with sleeve sometimes happens, it's bleeding. That's all. Now it's very safe procedure. It's my opinion. Okay, you have access. Try to share my presentation, and we can look details. Oh no, it's not this one. Oh, it's okay.
Yes, sir. We can see.
Okay. But it's only statistic. We can see how many sleeves perform worldwide, and we see it's green line. We see that it's really so many. We see how many complications after sleeve we can have. It's a leak, it's a bleeding, it's a splenic injury, it's a liver injury, it's stenosis, it's a venous thromboembolism. But if you can see, it's a little bit old slide. It's one of the first summit on sleeve gastrectomy. It's published in 2013 by Michel Gagné. It's a little bit like prophylaxis of the sleeve complications, but we can see that the leak it's about 1.3%. But anyway, if we see here the range from 0 to 18, it's too much. It's too much. Yeah. And sure, we understand that it's really different procedures. It's very interesting publications. when we can see the variation in technique for laparoscopic sleeve gastrectomy. You see, it's all clinic in United States who have a certification and put the data in the same base. We can see we have 463 technique variants of the sleeve.
Oh my God.
We understand it's completely different procedure. We understand the ideology, it's the same, but it's completely different. And only 17 technique, it's a little bit half of all procedures. Anyway, the very important things, the very important things, it's a size of bougie, it's a staple height, it's a resecting when it's beginning, it's a mobilization, how you do it, and reinforcement. It's very important tricks. What about safe sleeve? Always we start from angle of the stomach, we start mobilization, we cut the vessels, and entering to the sac under stomach. The second things, very important, the dissection of the gastrosplenic ligament and the angle of the GIS. If you see, we need to visualize diaphragm and angle of the GIS. It's a point of visualization. You can see on the slide how it must be. Because if you see the cruise, the left cruise, you must be sure that all the fundus you mobilize. It's a real important rule. That's this little video. It's okay?
Yes, sir. Excellent.
You can see we mobilize all this part. We need to visualize a left crura of diaphragm.
Alexander, routinely you use 4 trocar, or you also
always I use 5 trocars because I have 2 assistants.
Yeah.
It's depends. I think in private clinic it's very difficult to have 2 assistants, but in our hospital and big clinic with university, it's very simple because we always have somebody who have an education course and who wants to attend in procedure, and sure, it's very simple. The 5 trocars, it's very very convenient because you can really, in a case of really bulky fat in near the spleen, for example, you can do a retraction.
Yeah.
Because it's very difficult to do when it's really bulky. And you see this patient, for example, it's not very big, but it's typical Russian patients. We have a big visceral adiposity, and it's very useful to have an assistant. Okay. It's continuous mobilization. Sometimes we use we put napkins in the left part to divide the fat and the zone of the dissection. You see, and sometime when you dissect in this zone, you understand that you have a real big fundus. now we can see that our stomach, it can be folded. You can turn it completely left, completely right. You understand, and you completely mobilize. It's very important. Very important to dissect posterior wall. Often here the different adhesions, sometimes very, very strong between, for example, posterior wall of the stomach and the pancreas. Yeah. And but you need divide all this, because if you don't divide, you can do a right sleeve. You can take equally the anterior and posterior wall of the stomach.
Yeah. These are
okay. Yes. You asked something?
No, nothing. So these are the key points that you are highlighting, and it will be great message for our youngsters.
The very important moment, and it is big evolution in this field for me, for example, because in an early period we start to leave maybe 4-6 centimeters from pylorus. Now we mobilize completely to the pylorus, and we leave only maybe 2 centimeters from pylorus, and we start resection.
Yeah.
And you see your mobilization, how to do the traction. Important moment, it's using of the calibration tube. The many surgeons, I don't know how it's in other countries, but in Russia, many surgeons use the calibration tube with different different signs, and not specialized for the sleeve. Sometimes it's maybe 36, but it's nasogastric tube for feeding, for example. It's not good because it's not too good silicone. It's not very very solid, and you can understand how to. It's very soft. It's very soft. It's not convenient. I think you need a calibration tube. The best size is 36-40. It's the best size. In my practice, it's 39. I like, because I don't do the tight sleeve. I like the a little bit relaxed sleeve, a little bit more wide. How to put the calibration tube? You need to put firstly in duodenum. It's the best way to put the first cartridges, because you see it's fixed. It's fixed in pylorus, and you have the line when you start a resection. After the first firing, you need to pull up the bougie, the tube, and put it in antrum, because if you leave it in pylorus, it will be difficult to take equally the part of the walls of the stomach.
Alexander, this is a great point. This is a great point, really, especially for our youngsters. Yes, after first stapler, when it will be in antrum, so this traction with bougie is very important for next stapling.
Yes, but you see, it's normally it's 2-4 centimeters, 2-4 centimeters, and you see this the down left, down right picture, the bougie in pylorus, and we put near pylorus the stapler. Okay, when you can choose. It's not obligatory 2 centimeters. It's very important to look the angle of the geese or angle of the stomach. Why? Because the red point.
This
You need to not narrow
this angle.
the stomach. The most often place when you have stenosis, it's the angle of the stomach, because the first stapler ring, they often very close to angle of the stomach. And you see on these pictures, you can understand the distance between angle and the stapler line. You always must leave the equal distance, because if you put the less, if you leave the less, you will have a stenosis. It's important. Okay, then you continue your sleeve gastrectomy. Sure, you look the anterior posterior wall. It must be equally. It's very important. You always must turn your stomach. You look anterior wall, look posterior wall, and understand that it's really equal. The very important things for me, it's angle of the geese. I always leave a little part. I take 1.52 centimeters from angle of the geese to the left side, because in this place we have circular muscular of the stomach, and when you put it on the esophagus, you can destroy this muscular structure, and circular structure of the sphincter, a low sphincter of the esophagus, don't work. I think it's very important, and I always leave a little part. And maybe it's not, I don't have it's not proof, but I think it's a give possibility for patient have a less of the reflux after sleeve gastrectomy. And you can see on all pictures how it must be. Okay. I think the second things about reinforcement. In Russia, don't exist SIM guard or something else, some material for reinforcement. We use only suturing. It's only one way to do the staple reinforcement. In my case, I always do it, and you see it's a little bit old study, but anyway, the Michel Ganet do it 2014. You see oversteering suture, it's 2.0 licks. If you see no reinforcement, it's 2.6. It's a little bit different. And I think it's a very important role. The second role of the suturing, it's a prophylaxis of the bleeding from the stapler line. Okay, but it's how to do it. It's always imbrication, suture. I use normally PDS, and you can a little bit calibrate. If for example, you have a little bit more of posterior anterior wall, you can take more and calibrate by the suturing.
So it means when you imbricate this your sleeve, so definite your stapling is not very tight to bougie, little wide, then you have a space for suturing.
Sure. It's why I use a bougie 39 and why I do a relax sleeve because I leave a little bit from bougie. It's a little bit, maybe 0.51 centimeter from bougie to staplering. It's very good. It's always preserve you from stenosis. It's very important because for sleeve, I think it's a Achilles point. Okay. It's finished of my presentation.
Yeah, excellent presentation, Alexander. So I have some question regarding omentopexy. So are you agree and have any experience for omentopexy?
For my opinion, it's not useful because the omentopexy don't give us something. The omentum, it's very flexible. It's not tied. It's not to take something. For my opinion, it's not prophylaxis of something. And other things, if we do, for example, redo procedure after sleeve, we can see that omentum, you don't fix it, but anyway, it's completely fixed on the stapler line.
Yeah,
and I think it's not useful.
Okay, so as you have mentioned, so your evolution of sleeve gastrectomy, one point was just near to pylorus, and also,
Yes.
oh yes, this was very important that you have highlighted, and when you will be near to pylorus, and so then there is less chance of weight regain after sleeve gastrectomy, and also you have highlighted that in scissura angularis, that is the most important. There is more chance of stricture, and be careful. And also angle of his, that must be 1.5 centimeter.
Yes.
Sir, another question regarding your protocol about pre-op endoscopy and H. pylori eradication.
We always did endoscopy, preoperative endoscopy. It was always our protocol, and we still continue this procedure to do, because I think every third patient have some lesions in stomach, erosion or something else. And if we see the Helicobacter, we doing the treatment with antibiotics, and I think it must be treated before procedure.
So great, as you, Alexander, you have mentioned, so every third patient is, so there is some endoscopic finding, and definite you do biopsy from these lesions. So what was the routinely result of these lesions? Definitely there are simple benign or...
No. These lesions, it's inflammatory lesions. It's, for example, erosions, or sometimes maybe ulceration, but it's the different tumors or something. It's rare. It's not very often. But anyway, we seen and the GIST and some adenomas and others.
Because why I'm asking this question, because now you are practicing in a university that is so definitely you have more access to evaluate your patients, and it is easy to do as compared to, because I am practicing in Dubai. So definitely we face some insurance issues for pre-op endoscopy. We have some limitations. Definitely you will not face such a situation. What is my question regarding pre-op? Because this is a hot topic. Now we are facing all over the world and in different international conferences. So when you do routinely endoscopy, which percentage of your patient you have changed your plan? So that finding was incidental finding and patient was asymptomatic. There was no, oh, thanks God, I did endoscopy and now I will postpone and I will do another thing. So which percentage of your patients routinely you have changed your plan for surgery?
I think it's about 15%.
Oh,
yes. Sometimes we see in the esophagitis, CD, Barrett syndrome, sure, we need to change the tactics. Sometimes we see the herniation. Sure, sometimes we need to thinking to leave it or not to leave the tactics with sleeve. I think like this, 15% about.
Excellent. Alexander, what is your in your protocol absolute or relative contraindication of sleeve gastrectomy? Both absolute and relative.
It's Barrett.
Yeah.
And esophagitis D.
D. But you will go for esophagitis B, C, and symptomatic GERD. If there is no Barrett and esophagitis is not at stage D, you will go for sleeve gastrectomy. And in your experience, have you faced worseness of GERD in such a case? Cases symptomatic GERD before surgery, but there is no Barrett. That's just initial esophagitis. Have you faced worseness of GERD after sleeve gastrectomy?
But before the procedures, normally we do a treatment of these patients. And after treatment, we evaluated what's happened. If the therapy is okay and we see that it's completely good, we can do a sleeve. If not, we start to thinking to maybe change the plan. Because we know that one of the reasons of the esophagitis and reflux, it's obesity.
Yeah.
And eating disorders. And sure, some patients really don't have any heartburning after sleeve. For example, when they have before very, very big clinical symptoms. Sometimes it happens. It's need only very clinical investigations and clinical evaluations. We need to understand what happened with patients in every private situation.
Because again, sometime, as you have mentioned, so due to obesity, patient is suffering with the GERD. So we have no endoscopic finding in such a case. There is no reflux, no esophagitis, but still patient complain is GERD. So you treat with medicine, with PPI, everything, but again, patient suffering with GERD, definitely you have faced. And after surgery, when we do surgery and patient lose weight, yes, then it become normal and there is no GERD symptoms. So maybe that GERD was due to obesity, but sometime, because this is my personal experience, so again, patient is suffering with GERD, and you can't believe I had converted the patient to Roux-en-Y gastric bypass. Again, patient is suffering with GERD. Same complaint. So have you faced such a patient?
Who suffer with a GERD after Roux-en-Y?
Roux-en-Y also.
In my practice, I don't see the patients with severe clinical symptoms. I had some patients who have some symptoms of the GERD after Roux-en-Y, but it's very rarely. And I never do other procedures. Maybe these patients go to the other doctor. I don't know, but I don't see this.
Alexander, what is your protocol of post-op endoscopy, that surveillance endoscopy, especially in sleeve gastrectomy? Because nowadays the main issue is GERD after the sleeve gastrectomy. Have you any protocol?
In our protocol, we do it after 1 year. After 1 year.
And what is your routine finding in these cases when you do all of your patients endoscopy?
Honestly, we don't have 100% of follow-up of these patients, and it's I think it's a main problem And that's normally it's maybe 50% of the patients only coming, and we don't know what doing as a 50%. We try now to have a more follow-up, but it's difficult because in Russia, many patients coming from other regions. Sometimes it's very far, for example, from St. Petersburg. And sure, it's communications problem exists. And I hope in near future we can evaluate more precisely these things. But very important things. We see now many papers or articles about GERD after sleep. But if we see very attentive on this situation, the evaluation of the patient who was operated 10 years ago. I know my sleeve 10 years ago was not the sleeves that I do now.
Yeah.
I think it's very important. Maybe the little changing in procedure can do a changing in the spread of the GERD after sleep. Because I remember very well the first sleeves that I see, the staplering was near esophagus. It was big antrum. Sure, it's really, you understand why it must be have a reflux. Let's look how it will be in 5-10 years after, I don't know, in maybe 2025, 2027. Maybe it must be more clearly what really sleep do for other patients. But I know so many patients with a very good quality of life without some problem after sleep after 5-7 years, and we always need to understand that, for example, bypass it's popular now, but it's not absolutely safe.
Yeah.
Because we have an ulceration problem, it exists. We have a reflux problem sometime. If it's ruined Y bypass, it's chronic pain after ruined Y, it exists. And we need to understand what quality of life have our patients, and sure compare with this.
Absolutely agree, Alexander, because still bariatric surgery will have a long and hard journey to standardize. So which type, because we cannot standardize due to different ethnicities and different lifestyle. So it is much difficult to standard one technique at this globe. So yes, absolutely, you are right. Alexander, about my question about hiatal hernia. If you diagnose a hiatal hernia before surgery, so till which size you will go for sleeve gastrectomy, and you prefer to do hiatoplasty?
If I see the defect, real defect, on time of procedure, I always dissect this zone. Normally, if I see that esophagus at angle of the GIS in abdomen cavity, it's not going when you pull up the bougie, don't move on the thoracic cavity, I never dissect this zone, because I think that we destroy a little bit the ligamentum, all the ligamentums who take a stomach in right place. Sure, if I see the defect in the crura, I see that it's maybe more than 3 centimeters. Sure, we need to dissect. More than 2 centimeters, we need to dissect this. I dissect and I look. The very important rule: you can leave the sleeve, but it's very important rule to mobilize the esophagus. The stomach must be stay in abdomen cavity. If you see that it's okay here in abdomen cavity. It's good mobilization. You leave it. You do a ecography, and that's all. If I see that it's more than 3 centimeters defect, sometimes I think better to not do the ecography. It's better to leave the big hole and mobilization of the esophagus, the same things. Because the chance, if you do a ecography, that your sleeve must be strict by the crura, it's more high than you leave the hole. I think it's a little bit like this, my tactics.
Yeah, Alexander, some of surgeons, so they prefer to fix esophagus with the left crus.
I know.
Have you any experience?
I never do it. I think it's not good practice because the diaphragm always move. The esophagus too, and I'm not sure that it's working right. Sure, maybe we need big groups and investigation about it, but I never see the scientific with good proof of these things. I never see these articles.
Excellent. Alexander, sometime we face when we complete our sleeve and just we remove our bougie, you feel there is some twist in such a situation. Are you prefer to fix your this sleeve with the base of momentum or no need?
No, if you have a twist, you can do nothing. It's how the patients. You need to wait, because when it will be a liquid diet, it's okay. But smoothie diet, it's okay. But if it's start solid food, you can see your twist bad or your twist okay. You need to wait. It's not useful to fix because you can't fix it. It's a muscle. It's you can't fix it. It's not working like this.
But you will not prefer to fix at the same time when you're doing your surgery at the end of a sleeve gastrectomy. You feel there is some twist. So routinely, yes, I understand. You never fix this gastric tube, this is sleeve with momentum. But sometimes we face such a situation at that stage. So what is your suggestion? What we must do at this stage when there is a twist?
You see, if you see this completely twisted stomach, you need to redo to bypass, because it's not working like this. But maybe if it's very big patient with big BMI, you can leave like this, because the patients on liquid diet here lose the weight, and then you redo it. But you need to talk with patients that told us. I think it's with solid food you have a problem, because the twist, the patient the problem start with twisted sleeve when it start to eat solid food.
Yeah.
Because with liquid it's okay.
I understand. I take your yeah.
It's one of the tactics. But anyway, we don't see now the twisted sleeve, and I think it's because we. And one trick, what we do now, after procedure, I always pull out the bougie, and then I ask anesthesiologist to pull inside to look how the bougie going through your sleeve. It's very useful because you understand that it's okay, it's good sleeve. You see all the place.
Excellent. And already you have mentioned, so when your reinforcement is that stitching, and at that time you adjust if there is this posterior pouch, because routinely when we staple, So because the stomach anatomical position is so posterior pouch is so size is bigger because due to curve. So sometime, so when we step, yes, everything is looking good, but at the end we will see that this is little asymmetrical. But when you stitch this, so yes, you compensate and you can take the main part of this posterior side, and then your sleeve will be symmetrical, and then there will be no twist.
Yes, we can use the imbrication for do the sleeve more equal.
Yeah, more symmetrical,
more beautiful.
Definite. So Alexander, yes, you are also following, and as you have mentioned, 50% of your patient. So you are. This is also good follow up, in my opinion. And also you are a scientist. So which percentage of your patient are suffering with weight regain after sleeve gastrectomy? Now more than 1 decade, you are performing sleeve gastrectomy and your main practice is a sleeve.
But normally it's 20-30%. From 20 to 30 have a weight regain in our group. It's we have a very direct connection between how to patient going to follow up and how he lose weight, because our visits, it's a 1 month, 3 months, 6 months, 12 months. And every this visit, on every this visit, the patient, when you talk with patient, you understand what mistakes he doing, and you can help him to correct some eating behavior problems, some psychological problems, some problem with alcohol or something else. It's very important. It's very important. Because if you correct on all this point of visit, this problem, the patient have very good results, because he understand how to maintain the result, how to have the same behavior like was, for example, in the first 6 months. If not, sure, after 6, 7, 9 months, he receives the results or with weight. He is lucky, and he starts to live his standard life, and sure, the weight regain. I think it's 20-30% have a weight regain. We don't have so many patients with completely weight regain, sure. Yeah. But anyways, maybe I look the good meta-analysis. Maybe it's 2020, in maybe in obesity surgery. The 50% of patients after sleeve, after bypass, have weight regain about 25% of the losing weight.
Yeah, yeah.
50% of the patients.
Yeah. Definite. Alexander, so sometime because now about 5 years, you have standardized your technique, you did your best for the patient, everything was standard for sleeve gastrectomy, but again, patient weight loss stuck after 6 months, after 5 months, yes, lose weight, then stuck. So in such a situation, are you prefer to use any injection, any medicine like Saxenda, Victoza, or something GLP-1 derivatives?
In this period, never, because I think the period of the losing weight normally after all bariatric procedure, it's more than 1 year, because we have some patients. It's very important with patients with high BMI, because always we evaluate first year. It's not too much. It was, I don't know, 200 kilograms. Now it's 140. But normally, if this patient with good compliance, he continue lose weight. We like the I like more the new formula. It's semaglutide. It's very effective and very convenient for patient because you do it only once per week.
Yeah.
But we use it after 1 year. A better period it's after 2-3 years. It's better period for using agonist of GLP-1.
Okay, sir. Thank you. And also my question regarding GERD. So definitely this is a difficult question. So which percentage of your patients are suffering with GERD after sleeve gastrectomy?
I don't know exactly percent, but anyway, it's the heart burning have maybe about 25%. And they takes PPI. I think real GERD with esophagitis have minimum 15%.
So what do you think, Alexander? Because now, why I started this interview series, because I like a solution, and I will try my best, especially in sum up session, for a protocol. What we do, how we first of all we must evaluate why GERD after sleep. Yes, we know due to high intraluminal pressure. So when there is no stricture at this incisor angularis and our sleeve is standard, again patient is suffering with GERD. So what is my question regarding H. pylori? So have you any data? So these patients who are suffering with GERD were also positive with H. pylori before surgery, or they were suffering with some grade of gastritis or some issues, and already in their life they were suffering with a stage of GERD. Have you any data, or can you collect some data about this?
I don't evaluate this. Maybe we can find some connection between H. pylori and esophagitis or something else, some problem after sleep, but I don't have a clear data about this. And I don't see some scientific publication, big scientific publication about it. Maybe, but I think the first reason is a problem with high pressure system, because we understand very well if we have a tube and have two sphincters, low and high. If we have pylorus and hiatus, if the pylorus more strong than the hiatus, sure, when the patient eat more, he have a problem. But very important things. It's when it's one of the symptoms when the patient told that sometime I have a heartburning or something, symptoms of the GERD. You can ask him because sometimes the patient eat more than he can. And sure, these symptoms can be when he eat more. It's very important work, because I have some patient who had a heartburning, something, then we regulate the volume of the
Right.
Yes, and it's okay, no symptoms. It depends. It's very depend of situations. It's every patient. It's individual. We need to evaluate these patients. We try to have a very common decision for all. It's impossible. We need to find the individual solution.
So, Alexander, so for these patients who are suffering with GERD after sleeve gastrectomy, definite you do endoscopy for all of these cases. So my first question, what was your finding in these cases? And another question regarding H. pylori, which percentage of these cases were positive? Are you so routinely check H. pylori in these cases geared after sleeve gastrectomy?
We routinely check, but I don't have a data now for you. Don't have a data for you exactly because I don't know. We don't look this. We routinely do a H. pylori test for all the patients, but we prefer, we do it in different centers, but I prefer then when it's performing histological test of the H. pylori. It's more informative. And in other case, I don't know, but we need to see it. I don't know. I look.
So we can, yeah, because also I have discussed with other surgeons. So we can collect the data, the patient who are suffering with GERD after a sleeve. So which percentage of these cases are also suffering with H. pylori after surgery, and also they were suffering with H. pylori before surgery. So maybe we will help a sleeve, because why I am talking about safe sleeve. Yes, with the technique now you can see rare cases of leak, definite. Now personally also I remember my last leak was I think in 2014. Yes, now about 7 years. Yes, personally I have not faced due to this technical changes and reinforcement and different things. Yes, there is less chance of sleeve with technique, less chance of bleeding. So maybe we can help sleeve gastrectomy, because this is a good surgery and easy, if technical easy, but also there are some tips and tricks. So maybe if we evaluate this one, and also if there is role of H. pylori, we can eradicate. Alexander, another question for PPI. What is your routine? This PPI, how many months or weeks your routine practice for your patient in post of sleeve gastrectomy? You suggest your patient to use PPI.
3 months.
3 months you use, yes. Alexander, a critical question, maybe what will be your answer regarding endoscopic gastroplasty? Have you any experience, and what is your opinion?
No, we don't have experience with endoscopic gastroplasty because we don't have this device in Russia. And I know that, for example, in India, it's very popular, in South America, but we don't have it.
Alexander, really, it was a great honor and a great session. And there were many practical points that you have highlighted, and definite our viewers. It was great honor for them, and also opportunity to learn more about safe sleeve gastrectomy. Sir, any message for youngsters who are now going to start sleeve gastrectomy?
Don't afraid. You need to do the safe sleeve. You need to look all the rules about sleeve, and don't hesitate to perform all this advice, because this advice, it's experience of mistakes. And I think now it's very simple time, because when I start my first sleeve, I don't understand about sleeve nothing. And now you have possibility to use all experience of the worldwide, and try to take more, and try to do all the position, because it's not important the time, how many times you perform sleeve. It's very important how right you perform sleeve. And go ahead.
Sir, excellent and really appreciable. We need your support. Definitely, we need your guidance, and we will continue this series of interview series of sleep gastrectomy till December, and we will have a summer session. Viewers, so much thanks. I know in South Asia this is the late night, and yes, in Europe this is the best time to hear. And we have so many because we are also live at Facebook. If you have any question, you can ask question in your comments. Sir, again, so much thanks for your time. I know you are so much busy. We need your support and we need your guidance. And next week, we will have another legend, another expert of sleep gastrectomy, and don't miss that session. Alexander, so much thanks and really appreciable.
Thanks, Neymark. Thank you for invitation.
Thanks a lot. Thank you, sir, and hope see you soon. See you soon.
See you soon. Ciao. Ciao.
Thank you. Thanks a lot.